Good morning,
Hello.
everybody. Good
Hi,
morning. Am I audible?
Yes, sir. Audible, sir.
Okay. I take this opportunity to welcome all of you for this today morning CME program being conducted by Rajiv Gandhi University of Health Sciences. With respect to the present pandemic COVID-19 situation, the pursuit of RGHS is to see that correct information, authentic information is disseminated to all the concerned, especially the doctors, the specialists, and the healthcare workers, so that there will not be any iota of doubt in the minds of the treating doctors and healthcare workers. If you are confident, if you are equipped with knowledge, then you can treat others and also convince others. That's the pursuit of RGHS. In view of this is the second in the series of lectures being organized by RGHS during the second wave. And last time we had the first inaugural speech by Dr. Shashi Bhushan. He spoke on rational use of remdesivir and oxygen. And today we have with us an eminent speaker, Dr. Mahesh Kotapalli, an Indian settled in US. He is an infectious disease specialist and a very dear topic for him. And today he'll be speaking on the infectious disease, recent treatment protocol in the COVID-19 perspective, the international perspective. Dr. Mahesh Kotapalli is graduated from India, but now settled and was working in US. And his place of work is in Dallas, DeSoto, Bolton, Boone, in Texas. I welcome Dr. Mahesh Kotapalli, who is a dear friend of mine, and I request him to give his perspective of recent treatment protocol in COVID-19. We have been following a definitive protocol from Indian perspective. We'll also need to have what the international perspective or international view about the treatment protocols. I'm sure these speakers, the audience will have a lot of doubts in their mind. They can also get to know as to what is being followed elsewhere in the globe. And we very ardently follow the Government of India directives, and we also frame our own guidelines. Our state has already issued the 4.0 version of the treatment protocol, and which keeps it's a dynamic protocol. It can keep changing. We keep upgrading it as and when necessary. And we'll listen to Dr. Mahesh Kotapalli as to how this protocol differs, and if at all, why there should be any changes. And if any good thing is happening in the international scenario, why not we adopt it here in the Indian scenario as well? Keeping that in mind, we invite Dr. Mahesh Kotapalli to take over and give his comment, the lecture. Thank you so much.
Thank you, Vice Chancellor, and thank you all the physicians who have joined this morning. And before I start the thing, I want to commend all the healthcare workers, frontline warriors, for the brave job that they're doing. At the same time, I also want to let you know that if you are all vaccinated, there shouldn't be any problem for you guys. You should not be afraid to go inside and treat these patients. I myself was vaccinated. 2 months later, I did contract COVID, not through a patient, because I was careless with friends not wearing a mask, assuming that they all had vaccinations. So we all started playing cards together, one round table, and someone was carrying it. So I still contracted it. So that does tell you one thing about vaccination is, yes, if you're vaccinated, you will not, most likely not die from the COVID vaccine, but you will still contract the virus. You will still get the virus. You might be symptomatic or you might be asymptomatic. The only symptoms I had was loss of taste for about a week or so, but other than that, I didn't even know I had it. The only reason I found out is because I was traveling international and they tested me and I was positive. I quarantined myself until I became negative, but I just want to let you know that just because you're vaccinated, it's not a foolproof that you will not get the virus. You will still get the virus. You might not be symptomatic, but you will be spreading it to others. Therefore, the moral of the story is, please don't trust anybody. Always wear a mask around family members, around friends, around colleagues. Don't assume that anybody is negative. Assume everybody around is positive until this pandemic is over. So having said that, I want to thank the Vice Chancellor. We had a chance meeting at the dinner table, and then suddenly he said, why don't you tell us about your perspective? Because I went through the first wave in the US when India didn't have any cases, and I was showing the reports and x-rays and trying to educate the people over here. And the first wave comes in, and I was here during the first wave helping out with the protocols and everything. There were a lot of deaths, but surprisingly something happened, and then COVID kind of disappeared from the Indian scenario, where the hospitals were all empty, and we were sitting in US scratching our heads. What happened? You know, how did the Indians do this? You know, it's like such a big, huge population. What have they done to curb this so fast? And we were suddenly having a second wave in the US. And, you know, we were all talking in our lunchroom with the colleagues saying, what happened? What did the Indians do? So, but then again, suddenly the scenario changed. So the several questions were, what happened here? Well, one of the two things could be now you have a variant possibly. And then so second scenario people are discussing is the election campaigns, where people were congregating together in the thousands and thousands, weddings happening without any precautions. So I think that kind of caused a debacle here. And this new variant, possibly it's a superbug, I would say, is it spreads more rapidly than the first variant we had. So the virus itself is not deadlier than the previous one. It's just the contact rate is much faster. It spreads more easier. And that's why I see a tremendous spread in this community here. Therefore, I want to touch base with you on the treatment protocols that we're following over there in US. At the same time, I know you have your own protocols set by the government, and I'm not going to argue about that or disagree with that. You have your own protocols, but protocols are a paper to guide us. It's not written in stone. Remember that. As doctors, we have 110 protocols for every little treatment there is. But as physicians, it's our duty to take the good and the bad and see what actually works, what is the scientific data behind it, and treat the patients accordingly, and I think we have a better outcomes. Now, you know, as you know, there are a lot of studies come out. For example, for everyone, I'll just give a simple example. Alcohol. Several years ago, the studies came out having 2 drinks every night is good for health. It keeps your heart disease away. Then again, another study came out and said, no, only scotch is good. Then other people came and said, no, wine is good. The other one said, only beer is good. Then somebody, like my wife, comes and tells me that you drink alcohol every day, you're an alcoholic. So there's so many variants coming in. The new study comes in and says, yes, you can drink any drink for 1 or 2 a day, it'll keep you healthy. So there's so many things, new data is coming in. Just like that, we have new data coming in regarding COVID. One day it's out, one day it's in. So what's in, what's out? There's so many publications, there's so much data on the internet, and we have our WhatsApp driving us crazy. Every day someone puts in a new treatment protocol, and we're trying to scramble it. Yes, in the beginning, during the COVID origin last year, when we had no clue about how to treat a patient, we were just treating everybody that was popping on the WhatsApp. We take that thing, start applying to the patients. A lot of mistakes were done because we didn't know any better. A lot of bad treatments were given, inappropriate treatments given. But since then, a lot of studies have happened, a lot of publications have come out, but how do you know which one to really read and which one to follow and all that? I'm an infectious disease specialist, and there is a society called Infectious ID Society of US, and it's called Infectious Disease Society of America, IDSA. And their job is basically to review all this thing and put everything, pile in one context so that it's easy to understand for us. Now, so there were several drugs that came out for treatment. So they reviewed the research material, the study material, and then they did their own internal review to see which one is valid, which one is invalid, which one has a good p-value, which one doesn't have a good p-value, and they compiled certain recommendations. So I'm going to go quickly through the recommendations as to which are in, which are not, and I'm going to focus a little bit more on the clinical scenario that I'm seeing in Bangalore, and I'll make some recommendations towards that aspect, and then we'll talk a little bit about labs, radiology, and then towards the end, I'd be more than happy to take all the questions that you have, and then we'll have a good productive discussion. So having said that, I'm going to start the PowerPoint. So let me share my screen here. So you guys can see the screen now, okay? Can I get a thumbs up? Yeah?
Yes, sir. We can see. Please
All right.
go ahead.
Okay, so last one. What's the objective of this presentation today? I know we have so many pharmacological therapies that are used, but then again, there is a need for frequently updated practice guidelines on their use based on critical evaluation of the rapidly emerging literature. Now, these are the recommendations and updates from IDSA, like I mentioned before, Infectious Disease Society of America. This is a gold standard that we all follow. Number one is the hydroxychloroquine or chloroquine. This has been ruled out, strong recommendation against its usage. The next one is the hydroxychloroquine plus azithromycin combo that was being given. Again, strong recommendation against its usage because of high risk of arrhythmias. Next is the HIV medication, lopinavir, ritonavir. Again, strong recommendation against its usage because of severe GI side effects. Famotidine is an antacid. Again, it's recommended against its usage. Ivermectin, it's recommending against its use outside the context of clinical trials, both in ambulatory and hospitalized patients. Again, this is only being recommended for clinical trials, but in this country, I think, correct me if I'm wrong, the government has actually approved this. See that every patient that's hospitalized is getting it. There is no recommendation for or against it. Personally, we have not used in US. FDA has banned us from using this. And I actually, bit the bullet on one patient who was pestering me to use it on her father just to satisfy the patient. I just used it on the patient. It didn't do anything, okay? Convalescent plasma, a big controversial thing, a lot of literature out there. Again, the final conclusion is it just doesn't work. It's useless. Now, steroids. This is a highly recommended drug again. Dexamethasone is the number one choice here, strong recommendation of usage. Again, if dexamethasone is not available, you can do other glucocorticoids such as methylprednisone or prednisone. Now, for whatever reason, if a patient cannot get steroids because of any other contraindication, there is another medication called baricitinib along with remdesivir rather than remdesivir alone. This is a medication that has been used for rheumatoid arthritis, and they say that it maybe has some effect towards it, but this is not available in this country right now, so let's not waste our time talking about it. Now, among hospitalized patients with non-severe COVID-19, that means these are the patients who are just admitted without any oxygen. Their recommendation is do not use steroids on them if they're not on oxygen. Now, sorry. Next is the remdesivir. It's strongly recommended. Again, we have certain criteria in US because not only in India, in US, when there was a second wave, there was shortage of remdesivir, believe it or not. So in order to curb the overusage of remdesivir on unnecessary patients, we put in some protocols. One, if patient has to be RT-PCR positive, has to be admitted in a hospital and requiring at least 4 liters of oxygen to keep a saturation above 95% or 94%. If they are not requiring oxygen, or even if there are 3 liters of oxygen, we had to say, no, you're not going to get remdesivir because, first of all, the supply is less. Second of all, there is no evidence that you actually give remdesivir to these patients. It might help or it might not help. The literature still is out there. So our criteria is your markers of inflammation have to be high. You should require minimum 4 liters of oxygen, and those patients were given remdesivir. Again, by doing that, we were able to ration the remdesivir appropriately and give it to the people who really need it, thereby saving some life. Torqueless Map, controversial drug. The first wave, we used Torqueless Map on every ICU patient. And then around December or January, the literature came out, one study saying that Torqueless Map is useless. Even New England Journal of Medicine came back and said it has not shown any benefit. And so the hospitals were very happy with that because that Torqueless Map is very expensive. It was costing us approximately $4,000 for one dose. And that's a lot of money. So as soon as the report came out, the hospital said, okay, we're not going to give you tocilizumab anymore. Fast forward the time to time, and then we had the second wave. Nobody got tocilizumab. Some people died, some people survived. And then a few days after that second wave went away, two trials came out. One is the recovery trial, and another one is the REMAP CAP trial. Surprisingly, these two trials, it showed a benefit for tocilizumab. There was a 28-day reduction in mortality rate in this patient. So now the recommendation is, yes, you can use tocilizumab in ICU patients if you can admit them in appropriate time and the ICU admission is less than 24 hours. Or if the patient is really sick on the floor and he's on a high flow nasal cannula or a BiPAP machine, and if you have it available, you can give tocilizumab, provided as a clinician, you see that the markers of inflammation are going through the roof and the patient is clinically deteriorating, whereby he's requiring more oxygen and his X-ray findings are worsening. And you know, based on the respiratory rate and accessory muscle usage, this patient is gonna, get tired and is gonna require ventilation in a minute. Those kind of patients, if you have available, please proceed with tocilizumab. That's a recommendation. MABs. MABs are monoclonal antibodies. So these are neutralizing antibodies. Again, there are two drug combinations. One is bamlanivimab. The other one is casirivimab. These are the drugs that are given to ambulatory patients. Now, let's say that you have a patient who is severe advanced diabetes, COPD, asthma patients, and you know if they get COVID, they're not going to do well. Those patients, you can give this injection outpatient if it's available. It has shown to reduce the hospitalization in those patients, and I have given them myself severally in our clinic. When they come in, we have a COVID area where we infuse this one dose, and they did not get hospitalized. So that is something that if it's available, you can proceed in this country. So that's basically a summary of the three most important things that's going on. So based on that, I'll give you a summary of recommendations. And the first one is non-hospitalized, mild to moderate COVID-19. These are the patients who are ambulatory at home. If they're not at high risk for progression, then supportive care and symptomatic management. You can give them breathing treatments and you can give them paracetamol, things like that to get the fevers under control, cough medicine, and so on and so such. Now, there's another drug called favipiravir that is being authorized by the government of India. And initially, it was used in Japan for influenza, but they've been using it in Japan, China, and India. And it's interesting that the studies are showing promising evidence that this is actually reducing the length of morbidity on a patient, decreasing the length of viral shed on a patient. So again, this is initial stage, like I was talking about the bamlanivimab. In India, you have favipiravir. It seems to work in a patients who are mild to moderate, not requiring oxygen, and they're ambulatory at home. That is being used. If the patient is at risk of progression, like I said, those patients who are extremely ill and they have comorbidities such as asthma, COPD, etc., you can use neutralizing antibodies like the bamlanivimab or the casirivimab if it's available. Now, second set of patients are the hospitalized but do not require oxygen. Okay, I've seen a lot of patients in the hospital when I was rounding last few days. They're just there, but they're not requiring any oxygen. They're just sitting around. And there is no recommendation for remdesivir in these patients. So do not waste remdesivir on these patients because we are in severe shortage of remdesivir. So we need to save it. So don't give it to them if they don't need oxygen. Now, if you have plenty of remdesivir lying around in the coming few days, there's overstockage of everything. If you want to give it to them, give it to them. But in this scenario, when there's shortage of remdesivir, please don't waste it on these patients. Now, hospitalized patients that require oxygen. This is the most common patients that are coming in. Again, if you want to set your criteria and ration the remdesivir, my recommendation is to hold it unless they are less than 94% on room air, requiring at least 4 liters of oxygen. By putting those protocols in place, you can actually, like for example, one hospital is given 20 vials and they have 100 patients. How do you distribute the remdesivir? Who do you say is going to get it? Who do you say is not going to get it? Is it based on the influence or the important phone call that you get? This is my uncle, this is my aunt. Or are you going to establish a fixed protocol and stick to the protocol across the board saying that they do not meet the criteria, we cannot give it? Okay, by doing so, if you strictly establish criteria and they just can't question you, so that's our hospital policy. We don't have enough. These are for people who really require these kind of medication. So remdesivir can be given for patients requiring oxygen. Dexamethasone, this is the only drug that is actually saving lives right now. Forget about remdesivir, forget about Torqueless Map, forget about everything else. Steroids is your main gun. And dexamethasone, from what I understand, is very cheap here. From someone's side, it's like 10 rupees or 20 rupees a vial for 4 milligrams. And you have 4 milligrams and 8 milligram vials that's available over here. Now, dexamethasone can be given if the patient is on nasal cannula, just requiring oxygen on the nasal cannula, 10 milligrams IV every 24 hours. Now, the recommendations in the previous studies have shown 6 milligrams of dexamethasone, but my clinical experience after treating thousands of patients in the second wave is that we did not follow that recommendation. We went much higher. The reason we went higher is because we were seeing the patients were getting better faster and getting out of the hospital. 3 days, 4 days, they were out of the hospital. We're getting in new patients. We saw that, okay, giving more higher dose of steroids seemed to be beneficial. So we went up. We went up to 10 milligrams K24. Now, if that same patient now requires high flow oxygen or a non-mechanical ventilation like a BiPAP machine or anything, we actually went up double. We doubled up the 10, we went to 20 milligrams every 24 hours. Now, if the patient deteriorates further, and then we actually see that the respiratory distress syndrome has set in, X-ray is getting worse, his oxygen requirement is getting worse, then we're moving to Torqueless Map. So next is hospitalized, sorry to do that. Yeah, hospitalized and ventilated patients or patients who are requiring ECMO. We actually doubled up on the 20 milligram again. That means we went 20 milligrams twice a day on these intubated patients to a point where we keep them on 20 milligrams. Question is, how long do that? As long as they're intubated. Some people said 5 days, some people said 10 days. Well, we tried to do that. We tapered it in 5 days, they got worse. Then we waited for 10 days, we tapered in 10 days, it got worse. So we decided collectively, our critical care team in the ICU, we said, you know what, let's just forget about the book, let's go with this. Let's put them on 20 milligrams twice a day until they get extubated. Once they get extubated, then cut it down to 10 milligram daily. And then once they've weaned down to 4 liters of oxygen, then you can actually taper it off with tapered dose of prednisone, and I'll talk to you about it towards the end. Now, Torqueless Map, the patient, if they're admitted in the ICU within 24 hours, if you can get it, give it to them. If you can get Torqueless Map even on the floor patient who you see that is deteriorating and is going to require ICU pretty soon, go ahead and give Torqueless Map if you can get it. So those are the recommendations for that. Next one is labs. These are the basic labs every patient who's admitted in the hospital should get. RT-PCR, if they already have an RT-PCR, that's fine, you don't have to repeat it. A basic CBC, a comprehensive metabolic panel, sed rate CRP, LDH, ferritin, and D-dimer. Now, these CRP, LDH, ferritin, D-dimer, these are the ones actually kind of tell us which way this patient is going. He's going to the good side or the bad side. Now, these elevated markers of inflammation, C-reactive protein, LDH, and ferritin, will also tell us, is this patient going to the ICU pretty soon or not? Okay, if you have the resources and the patient is critically ill, and if you can do it like every second day or every third day. You can repeat the markers of inflammation. But if you don't have the resources, then clinically you can follow. I know Indian doctors are the best clinicians as far as clinical is concerned. They really don't need a whole lot of labs, but if you can do it, do it. Now, out of all this, ferritin is the biggest marker for COVID inflammation. If it's going high and high, you know the patient's not going to do well. Go up on the steroids, don't hesitate. Now, there's a reason why I highlighted the D-dimer and put some stars on it. Let me tell you something about this. This, you have to imprint in your brains that this is the one that is going to make a difference in the treatment protocol. As soon as the patient comes into the hospital, if the D-dimer is elevated, do not put them on prophylactic dose. Please go with full dose anticoagulation. Enoxaparin 1 milligram per kilo body weight. There are some doctors out there who think that giving ideal body weight is the right way to go, but that is absolutely untrue. That is not the right way to do it. You have to go full dose anticoagulation like you're treating a pulmonary emboli. Now, in a patient in the ICU, only 2 drugs that can save them are steroids and anticoagulants. I've seen patients who are coming in and not getting this kind of treatment and they're deteriorating. The reason I say that is because COVID-19 virus is prone to causing thrombi, microthrombi, large thrombi. So please keep in mind, once the microthrombi sets in the major organs, you're going to have organ dysfunction. The major organ here is lung. Lung itself has blood supply. So if that blood supply is blocked by microthrombi, there's no perfusion going on. Same thing with the heart. If the heart blood vessels are clogged with microthrombi, the heart's going to give in. So if the D-dimer is high on admission, please do not hesitate to go full dose anticoagulation with enoxaparin. If the patient is in renal failure and enoxaparin is contraindicated, switch to heparin. Now, if the patient is bleeding, for whatever reason, then you just stop it and just pray to God that he survives. Next one is imaging. All patients who are admitted into hospital requiring oxygen should mandatorily get a chest X-ray. That is mandatory. The reason I tell you why. 1, is this patient really from COVID? Is this patient having a congestive heart failure? Because there's so much COVID going on, everybody's forgetting about the other causes of hypoxemia, like congestive heart failure. Or is the patient having a COPD exacerbation or something else? Or did this patient have a huge cavitary lung lesion, which TB? And without checking them, you're going to put them in the regular ward of other COVID patients. Now this guy is coughing like crazy. Along with his COVID, he's exposing everybody else for pulmonary tuberculosis. So it is mandatory that we get a chest X-ray, make sure that it's not any other cause for hypoxemia, including TB or congestive heart failure, and then start the treatment. If you see cavitary lesions, suspected TB, isolate them separately in a negative pressure room. Next one I'm talking about, CT angiography. CT angiography, again, there are limited resources. Not everybody can get a CT scan in a hospital because hospitals are crowded. So we have to ration who gets, does not get. If a patient comes to the hospital, severely hypoxic, and you see the D-dimer is elevated, there's a high suspicion for pulmonary emboli, then those patients are the only ones who should get a CT angiography. If for whatever reason, this person cannot get a CT angiography due to various reasons, then and the D-dimer is still high, assume that this guy has a PE and treat him as such. Remember earlier I told you everybody who has a high D-dimer should go on full anticoagulation. Now you get a CT scan to confirm it, but if you cannot get, assume it. You're treating him full anticoagulation anyway, the treatment doesn't change. So don't go crazy for the CT scans and try to overcrowd the radiology department demanding CT scans. No. If the D-dimer is high and there is a high suspicion for PE and you can get a CT, If you have the access to a CT, then get it. If you do not have access to CT and the D-dimer is high, go with full anticoagulation under the assumption that the patient has a pulmonary emboli or some kind of a clot somewhere. So don't be afraid to go with that. Venous Dopplers. On your daily rounds, if you're going, the other day I was rounding on a patient and the sheet was above the knee, and I just saw that her right leg was swollen. And people are not paying attention to that. The reason is because, one, everyone's wearing that hazmat suit. It's hot as hell. It's already summer in India. It's hot. And on top of it, they have a N95 mask. On top of it, they have a shield. Your visibility goes down and your focus is elsewhere because you're looking at the ventilator machines, you're looking at the drips, you're talking to the nursing staff, you're looking at everything else, the family's driving you crazy outside. There's so many things, the doctors are going crazy. But always remember, when you're going on your morning rounds, just make sure take a look at their legs. Venous Doppler if there is any edema or swelling because they are prone to clots. However, you can overcome this initially by doing a D-dimer. If they are all high D-dimer, then put them on full dose anticoagulation so these clots don't happen. So, but if you do a if you do see a swelling in a leg, venous Doppler is the way to do. Now, there is something called HRCT chest being done here a lot. And for the love of God, I did not understand why. And I was actually, again, rounding in the hospital. Like I said, there was this patient sitting in those non-oxygen rooms and they didn't have a mask on and they were on the phone, shouting, talking. I just watched him from the door for 5 minutes to see if he'll get short of breath. That guy did not get short of breath. So I went inside and said, why are you here? What was the reason for your admission? I don't know, sir. Someone said, took a CT scan and they said I had COVID and they asked me to get admitted. So I was like, why did you have a CT chest done? Well, my RT-PCR was negative. Okay, so this patient's RT-PCR was negative, but someone decided to do a CT chest on a patient who's not having any symptoms except for maybe mild cough. They did the CT scan, they saw the infiltrates, and they put the patient in the hospital. And this guy, even today, is sitting in the hospital, occupying a bed for no good reason. Whereas I'm seeing ambulances crowded outside the hospital waiting for beds for other reasons. And unnecessary patients are being admitted for positive findings on a high resolution CT scan. Please don't waste your resources. If a patient is suspected to having a COVID-19 and they have mild symptoms of cough, if the RT-PCR negative, if there's a suspicion, just ask them to isolate themselves. Come back and repeat RT-PCR in 2 days if you want to. You can repeat it the next day also if you want. But if the patient is asymptomatic, don't do a routine HRCT. And based on the radio, you're not treating a patient here. You're treating a CT chest. And that's not what we do. We're not treating radiology, we're treating patients. So by doing this, we are actually scaring the people to go get admitted in the hospital and thereby occupying beds, which are actually needed for people who really need the beds and they're sick and they're not getting the beds. So I urge you, please do not order routine HRCT on patients who are asymptomatic. If the patient has some kind of a comorbidity and you really want to see if the patient has COVID or 19 and you do find it, then tell them to isolate themselves in the home, away from everybody else. There's no reason to scare them to send them to a hospital and occupy a bed unnecessarily. I talked about this anticoagulation. I'm going to go one more time. If the D-dimer is elevated, assume there is a clot somewhere. It doesn't have to be in the lungs. It can be anywhere in the body. Confirm with CT angio if you're available, or just treat it as such. Okay. Go with full anticoagulation, enoxaparin 1 milligram per kilo body weight. If I am 200 kilos, then I get 200 milligrams twice a day. There is no such thing as enoxaparin for ideal body weight. Okay, I don't know who's reading this literature, but it is not the right way to do it. You have to do 1 milligram per kilo. Someone said that the body fat doesn't have good blood supply. That's not hogwash. If I were to cut a fat person, he will bleed. There is some blood supply there. So don't go with that argument. please, the indication is full dose anticoagulation. And if enoxaparin is contraindicated, go with weight-based heparin or Eliquis. This is available in this country, apixaban, I've used it. So this is also an easy way to do it, a cheaper way to do it if you cannot get the enoxaparin or heparin and you don't want to monitor the PTT and all that stuff. Or warfarin, again, it's another cheap alternative if you want to give. At the time of discharge, let's say this patient has high D-dimer on admission and you did everything and successfully treated the patient is getting better, he's off oxygen, now he is ready for going home, you please give them 1 month supply of either apixaban or warfarin, because I have seen so many COVID patients coming back with pulmonary emboli or some kind of a clot somewhere in their body. So we came up with a protocol saying that, okay, all these patients with high D-dimers are going home, please give them 1 month supply of anticoagulation and then monitor them as outpatient remotely if you want to, okay? So that's one other recommendations that we're making. Now, this is another important aspect and is very dear to my heart. Infection control and antibiotics. Again, as you can see in the hospitals, people are wearing PPEs. And these PPEs are nothing but an oven. It's like a baking oven. They're wearing this all day long. They're sweating inside and they're irritated. The body heat is out of control. Nursing staff, everybody's wearing this. Once you go inside, nobody knows who's who. Everybody looks the same. Please put a sticker on your body saying, I'm doctor, I'm the nurse, so that people can identify who's who coming and treating. Number 2, the shield. Yes, shield is very important. Remember, the only 3 points of entry for the virus: nose, mouth, and eyes. The virus cannot enter your body from anywhere else in your body. These are the only 3 entry points. If you can cover these points, that's all you need. When I'm going into COVID ICU, I have my glasses. I can't see without them. So I have my regular glasses and I have a shield and I have my N95 mask and I have my lab coat. I go inside. Remember, I didn't get COVID from them. I got COVID from playing cards with my friends. So what does it tell you? This is all you need. So, however, I'm not going to argue about fighting about, okay, don't use this. Everyone's comfort zone is different. They're fine. In our hospital that I'm consulting right now, the doctors that I'm using along with me, we're all using the basic covering of this area, and that's all I need. And if you are not comfortable, just wear scrubs, go inside, finish your thing. When you come outside, go take a shower, put your regular clothes and go home. Now, the third point here I'm talking about is the gloves. I have noticed that a majority of the population inside the hospital, outside the hospital, in the community, everybody's wearing gloves. This is the biggest blunder people are doing, is wearing gloves. I go to a restaurant, everybody's wearing the gloves. And these gloves are not taken off regularly. People are wearing gloves from several hours at a time. I tell you one point, when I went to Ferritin for dinner, this waiter was wearing the gloves. With the same gloves, he took my temperature, wrote my name down, and took my number. Then he went and punched the computer, touching the same glove. And then he took the tray, went and got the food, tried to serve us with the same glove, came back with the same glove, he picked the dishes and walked away. I called him and asked him, why are you wearing gloves? Because for me, it's a pet peeve. Pet peeve means I hate that. So he said, sir, this is our policy. So I called the manager and I tried to educate them, saying that this guy is actually spreading the virus with his hands. Same thing in bus stops, airports, hospitals, inside the hospital, outside the emergency room, patients, families, everybody's wearing gloves. Guys, remember S.P. Balasubramanian, how he died? Because he wore gloves. Gloves give you a false sense of protection. Once you put on the gloves, you're touching everything, but you're not cleansing yourself. And you're in a false sense of security. You're going and touching everything around you. Your pen, your shield, everything is being touched. You're just spreading this virus all over yourself with these gloves. Now, if you don't wear gloves, by default, you're sanitizing yourself constantly, which is actually very protective for you guys. Not the gloves. Gloves will kill you. The only people who are supposed to be wearing gloves are the people who are directly in patient contact and patient care. They're the doctors and nurses who are actually in the hospital treating those patients. I also noticed one thing. They have the hazmat suit, they have the shield, they have the gloves. I'm talking about the doctors and nurses. From the same gloves that they put on initially, the long gloves, they're going and touching everything. They touch the chart, they treat the patient, touch the ventilator, they clean the urinal, they do the fecal material away, they're cleaning everything with the same gloves, same hands. They're going touching the next chart, next patient, because for them, they don't care. Inside, they are supposed to be safe. Outside, what happens, they're not thinking. Now, how can you go and say that you take off your gloves? They said, we don't want to get COVID. Well, there's another alternative. Once you have your underglove, the main glove, sanitize yourself or put a second glove. Go treat that particular patient. Once you're done with the patient, remove the second glove, sanitize the first glove again, put on a second glove, go to the next patient, so on and so forth. At least this way, you're not spreading infection from one patient to the other. Now, when you say infection, I'm not talking about COVID infection because they already have COVID, so there's no point. What I'm worried about is MDROs, multi-drug resistant bacteria you see in these ICUs. I have seen some bacteria in this ICUs which is resistant to every known antibiotic on earth. So what are you going to treat the patient with? Let's say that the most dangerous person who's the person who comes from another hospital. This patient has been in another smaller hospital and they did whatever they can, intubated whatever, and it's out of their control. Now they're pushing that patient to a bigger hospital with people who have better skills. God knows what they give over there, because everybody who walks into the ICU or hospital, they're getting antibiotics, and thereby creating multi-drug resistant bacteria. And that person now ends up into your prestige clean ICU. A new patient from another hospital has come in. You don't think about that. This patient came from a different place where you don't know what it looks like. You don't know what treatment was given. You don't know what bacteria this guy's harboring. You continue treating just like everybody else. Let's say you have a 5-star ICU and 20 beds, pristine. These are all patients that came directly through your emergency room. All your friends, family members got admitted into the thing. You are comfortable that these patients don't have. But how do you know about the patient who came from a different hospital? How do you know what bacteria they're carrying? How do you know that they don't have a multi-drug resistant Pseudomonas or Acinetobacter that they're harboring and they're bringing it in with them? And now your nursing staff or your doctors are innocently touching the patient, sucking the suction tube, changing beds. Now your gloves are infected. Now you take it to the patient next to you and then start suctioning the patient's ET tube with the same gloves, thereby introducing a bacteria into their lungs. Boom, you got a secondary bacterial pneumonia on top of your COVID. That is a done deal. The patient is dead. It's very, very important to think about this. Keep that in mind that we don't do this thing. We have instructed a protocol in this hospital where I'm consulting, whereby if a patient is transmitted or transported from another facility, he goes into immediate isolation. Pan cultured, sputum culture, nasal swab, urine, everything is cultured and kept in isolation until the cultures come back, which takes 2 to 3 days. Once the cultures come back, if nothing is growing, then we put them in the regular population. If not, we keep them. If there's a dangerous bug, we keep them in isolation. That's the only way. If not, it's going to get out of control. Forget about COVID. Patients are dying with secondary bacterial infection with highly resistant bacteria. We don't want to give them any new gifts when they come to our hospital. A gift that a hospital gives to a patient is an infection. We don't want it. They already came with a lot of problems. We don't want to give them a secondary problem. COVID is fine, patient died of something else. But we assume they died of COVID. So keep that in mind about infection protocol, infection control. On a patient who's admitted in the ICU or regular floor, if infection is suspected, let's say the white count is going through the roof. Now, the white count could go up because of the steroids, or there's no guarantee that steroids will cause white count elevation. Sometimes it does, sometimes it doesn't. But let's say the white count goes up and now you're thinking, oh my God, this patient has infection. Yes, that's as a clinician, it's a very good judgment. Then please, you want to give antibiotics, go ahead. But before you give antibiotics, you have to pan culture them. You have to get a sputum culture, a urine analysis, and a urine culture and a blood culture. Remember, talking about urine culture, do not do a urine culture without a urine analysis. It's like a wife and husband, they always go together. Urine analysis and urine culture. Do not order them separately, all of them together. The reason I say is, if you do a urine culture and it's growing 2 or different bacteria, your tendency is to throw antibiotics at the patient. However, if you have a urine analysis and the urine analysis shows only 5 to 10 WBC, that infection is not real. That is colonization. You really don't have to treat that patient with antibiotics. Just change the Foley catheter, that's all you need. So when you're doing urine culture, please hand in glove, always do a urine analysis. In the urine analysis, don't look at anything, just look at the WBC count. That is your clue to say if it's a real infection or colonization and treat accordingly. Now, if the patient has central lines and is intubated, sputum cultures and blood cultures are very important. One more thing I noted on the central line is they put a central line in the IJ and they're covering with a piece of cotton and they're putting a brown colored tape on it. And it is not sterile. The way I'm looking, they're not doing it in a sterile fashion. They're supposed to be done in a sterile fashion. And then once that is done, you're supposed to cover it with a tegaderm, which is visible to the outside. So what's happening is you put a cotton on top of it, put a brown tape on it. Nobody knows what's going on inside. The skin bacteria now has direct access to your internal jugular vein because of the portal entry of the triple lumen catheter that you have placed. Boom, you have sepsis. What kind of sepsis? A multi-drug resistant sepsis. Where did you get it? You introduced it. How did you do it? You touched that area with your dirty gloves. Remember that. Infection control in the ICU and regular wards is you have to think about it. When you are going to add antibiotics, I have no problem going with broad spectrum antibiotics because you see a lot of resistant bacteria in this country, so go broad. But once you get the cultures within 3 days, please just don't stay on the antibiotic, narrow it down. There was one patient I was rounding and the doctor was saying the patient was on meropenem, Zosyn, and vancomycin. I'm like, you already have a meropenem, which is a Mercedes-Benz. Zosyn is a Toyota. So why are you driving in 2 cars? You don't need to drive. How do you drive in 2 cars? It doesn't make sense. You already have a Mercedes, which is meropenem. Stick with the meropenem. He has a central line. He has covered for MRSA, which is vancomycin. Wait for the cultures and de-escalate the antibiotics if you have it. So that's the thought process you have to do. And please keep these lines in mind. Don't put them in the groin unless it's an emergency. You have 24 hours to remove it from the groin. And the neck one, again, another dangerous one is please don't put that brown tape and cover it up. Put a tegaderm or a see-through one, or keep it sterile. Don't touch it like regularly. And if you see the patient is like drooling from the side of the mouth and contaminating that area, do something to stop that. That's the only thing about infection control I'm talking about. The final thing is the discharge home. If the patient is comfortable on room air, then please do a 5-minute walking test. Make them walk in the corridor and do oxygen saturation. If the oxygen saturation is about 92 to 94 and the patient is asymptomatic, discharge home, get that bed opened up for somebody else. Now, also tell them at the time of discharge that you are not going to get better right away. It will take several days to weeks for you to come back to your full capacity. Walk a little every day, do your daily activities of living, go into the bathroom, cooking, cleaning, take small steps, and slowly increasing your oxygen capacity, exercise capacity. Don't expect that, boom, you're going to get better. There are some patients sitting around without oxygen just because they can pay, or they don't want to go because they're afraid. Educate them. Please tell them that you are fine. You're not on oxygen. Go home and quarantine yourself. You need the bed for somebody else. If the patient was on steroids during the stay, then taper off. When you come off the oxygen, taper off to prednisone, 40 milligrams twice a day, 20 milligrams twice a day for 2 days, and 10 milligrams twice a day for 2 days, 5 milligrams twice a day, 2 days, and stop. So this is the tapering dose you can discharge them on. If the patient's D-dimer was elevated on admission, then the discharge for 1 month supply of apixaban 5 milligrams daily. If your renal dose, if the patient is not able to take it because of renal clearance, then you can do 2.5 milligrams if renal failure is noted. If apixaban is not available, you have Coumadin to use. So that will be the last part of my talk. I'll open up the forum for any question and answers.
Hello, thank you, sir. Thank you very much. Now I will ask the Rupashri to take over the question and answer session. Hello, Dr. Rupashri.
Yeah, thank you so much, sir.
Yes.
Sir, thank you so much for your excellent speech. I'll just read out this question for you. So we have a question from Mr. Avinash M. What about methylprednisolone alternative to dexamethasone?
Yes, we can give it. I just
Okay.
mentioned earlier.
Yeah.
The
Thank you,
way,
sir.
the way I do it is I take about 12 milligrams or 30 milligrams, whatever you have, and then put them in a, what is the normal saline vials you have? Is it 250 or 240 ml that you have here? Is it 250, right? The normal
Yes,
saline
sir.
vials. So you can take that 30 milligrams or 40 milligrams of methylprednisolone high dose and put it in that bag of 250 milligrams of normal saline and let it drip over 24 hours. Calculate such that the 250 ml is running into the patient for 24 hours. The drip, 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 not one shot. So what happens is by giving methylprednisolone like that, you have a constant level of elevated steroids in your blood. If you give methylprednisolone one dose, the curve comes down after 8 hours. You give another dose, it goes up, it comes down again. You give another dose, it goes down, the curve comes back. So when you do that up and down, the therapeutic effect might not be there. So by putting that, the one I did was 12, now recommendations up to 34 you can give per day. So take the entire thing and then put in 250 milliliters of bag and then titrate it such that the entire thing is run over 24 hours. So you have 24 hours, so you can divide that and see how many drips you want to give to that patient.
Okay. The next question is from Mr. Sachindra. So he
Ma'am,
wants
can
to
I
ask about, 1 second, sir. I will just finish whatever is there in the chat box. Then we will open it for you, sir.
Okay.
Okay. So one more question is about IL-6 value in correlation with COVID-19.
Again, IL-6 is one of the markers that we use to see if it's high, should we give tocilizumab or not? And that's the only way we have its uses to kind of tell us, hey, it's getting worse or it's about okay. It's too high, then hey, high risk for cytokine storm setting in, so you need to give tocilizumab. That's the only way I see the use for IL-6. But if you don't have IL-6, like what I noticed in Bangalore is I ordered IL-6, it took me 4 days to get it. Report.
Okay. Thank you, sir.
I don't see a big use and wait for it. Don't depend on IL-6 to make a determination. You have other markers of inflammation, ferritin, LDH, and C-reactive protein. And if you see them going up, the patient's oxygen requirement is worsening, proceed with tocilizumab if you have it available.
Okay. Thank you, sir. One more question is, can we use budesonide capsules as in nebulization?
I don't see a problem with that.
Okay. Okay. Thank you. And one more question from Mr. Mohan. Is there any role for azithromycin?
Azithromycin, again, if the only thing azithromycin covers is strep and atypicals. By the time these patients are coming in, not strep anymore, you're getting high resistant bacteria. The studies have shown that use of unnecessary azithromycin is leading to arrhythmias. So I don't see a reason to start azithromycin in any of these patients. And it's not effect on-
Okay. So one more question from Avinash. What is the criteria to give italizumab injection?
What is that one?
Italizumab injection.
Is it a monoclonal antibody? The MAB?
Yeah, sir.
I'm not familiar with that drug. Maybe it's a different brand name in India. Do you have a generic name for that?
Okay. Okay, sir, we'll get back to you. So one more question is, everywhere people are forced to take vaccination, but not all of them are having same physiological conditions. So they have sudden fatal effects or whatever. So is it right to take vaccine? From Mr. Senthil Raja. Yeah.
Everybody should be vaccinated.
Yeah.
No matter what. That is the only way we are going to survive as a species. Unless everybody gets vaccinated, there is no contraindication at all. I'm an infectious disease specialist. I treat a lot of HIV patients, AIDS patients. All my patients, I made sure they all got the vaccines. All my elderly patients got vaccines. All my patients who had several allergies, some patients said, I have penicillin allergy. Please, there is no contraindication, take it. Everybody should be vaccinated. Yes, you might have some side effects. These are not just like adverse reactions like fever, body aches. Yes, when I took my second dose of Pfizer, it's half day into my rounding on the hospital, I couldn't even stand. My body aches were so severe. I went home and took some paracetamol and I slept. The next day I was fine. Same thing with Johnson & Johnson. Same thing with Moderna. I don't have experience with the Indian vaccines, but I've seen what some of the colleagues, they all taken it. They're all fine. And one of the doctors who actually had the vaccine, she got COVID, but she's asymptomatic. But she's still quarantined to protect the others, but she's completely asymptomatic. So that's what I'm trying to tell you is take the vaccine. The vaccine doesn't mean you won't get it. You will still get the virus even after vaccine, but you won't die from it.
Okay. Thank you, sir. Sir, here is a question from Dr. Girish. He wants to just speak you regarding plasma therapy, sir.
I just told you it's not indicated anymore. It has no
indicated.
Don't waste your money on it.
Okay, sir. Okay. So, okay. One more question is, does dosing of enoxaparin related to levels of D-dimer or full dose given irrespective of how high they are?
That's the one. Full
Yes.
dose irrespective of high. If they're higher than normal, just go full dose. Assume there's
Okay. Okay, sir, there is a question. If the patient got COVID and admitted in hospital after first dose of vaccine, after recovery from COVID, when to take the second dose?
2 weeks.
2 weeks. Okay, thank you, sir. And a question from Dr. Joel Paul. Is there a clinical role for genome sequencing or VOC PCR for patient management?
At this point in time, no.
No. Okay, sir. So the next question regarding remdesivir, how early or late can remdesivir be started?
Remember, I just told you in my lecture that once the patient goes into ICU, remdesivir is useless. You're just wasting your money and resources. If a patient is admitted in the ICU, it is too late for remdesivir. So my strong recommendation is don't use remdesivir in ICU patients. Save it for the floor patients who are requiring oxygen 4 liters or higher. So this is where a physician's role as a teacher comes into the community. In the community, people and most of the doctors are under the impression that remdesivir is a God's given gift for COVID-19. It's not. It's just an eyewash. It can help if given early on. Once the cytokine storm sets in and the patients are moving into high flow or going into the ICU, remdesivir doesn't work. If the patient comes to the hospital in a timely manner and on admission, if you see that oxygen requirements are more than 4 liters, give it for 5 days only, not for 10 days, 5 days only.
Thank you, sir.
It's useless. Mainstay is steroids, anticoagulation. If you can get Torqueless within the first 24 hours of ICU, you can use it. It works. But other than that, when I say it works, it might work. I'm correcting myself. It might work and it might help. But other than that, once the patient comes to ICU, remdesivir is useless. So it's to us to educate the family members saying that my father's in the ICU, they're not giving remdesivir. It's not available. Where are they going to get it from? But even they get it, there's another patient on the floor that requires it. Why are you wasting remdesivir on a patient in ICU when it doesn't work? It's too late. The boat's gone.
Okay. Thank you, sir. So one more question from Dr. Shashidhar Kharpur. He says, excellent talk to you. Thank you, sir. If patient is not responding to tocilizumab, some centers are using ulinastatin. Any experience with this?
What is that? Sorry?
It is ulinastatin.
I don't, it's a statin drug for cholesterol.
Yes.
I don't see any evidence base for that. Like I said, remember early on I said that everybody's using what they want.
Okay.
But there are no proven efficacy for anything.
Okay, one more question, sir. Is remdesivir and steroids are safe in case of pregnant COVID positive patient?
Yes,
Yes. Okay.
I have given it.
Okay. Thank you. So one more question from Ganesh Goda. Everybody wants to know, but I don't think we have an answer. How long this pandemic lasts?
Unless everybody gets vaccinated, my friend.
Yes, sir. Yes, sir.
And everybody's wearing a mask, assuming everybody's infected, even your family members. How do you know your son or daughter who's playing in the cricket outside? The school's gone, they're all enjoying themselves in the apartment complex, they're playing some games down there and they're not getting it to you. Until this pandemic, the wave is over, please make sure that everybody is wearing a mask around everybody else. And until every human being is vaccinated, this virus cannot be suppressed. And let's say this wave is over, this virus is going to sit down and say, okay, this buggers are doing something, they're wearing masks and they're getting these vaccines. How do we protect ourselves? Remember, everybody's trying for their survival here. The human being is fighting for his survival. The bacteria who's been here even before us in this earth, they're fighting for their survival by developing resistance to antibiotics. How do you think the virus is different? It's also fighting for its survival. Now, how does a virus survive and how does it evolve and what does it do? There's something, remember influenza? We're all doctors, we all know what influenza is. Antigen shift and antigen drift. That means every virus has a coat. All the virus does is, today I'm wearing a white coat. So my antibodies in my body are recognizing Mahesh with a white coat. So it knows how to kill Mahesh with a white coat. After a few days, Mahesh's white coat is smelling, so he takes it off and puts a black coat. The body now doesn't recognize, it recognizes Mahesh, but it doesn't recognize the black coat, so it doesn't have weapons to kill him. It just comes, oh, this is a black coat, this is not Mahesh, goes away. So that's how the virus changes itself. The antigens on top of the spikes, they keep changing it. So if we don't vaccine everybody really fast, the vaccines that we have taken now become useless because a new mutant has developed. And furthermore, going forward for the next several years, we all have to take this vaccine on a yearly basis, just like how we were taking the flu vaccine every year. This is going to be part of our life, that we have to take a vaccine, COVID vaccine for the rest of our lives, maybe every year. Until then, this is not going to go away. It's going to keep coming back. It's going to keep coming back. It's going to ruin our lives. And the only way to get back in control is quarantine ourselves, wear masks, and vaccinate everybody. There's no other choice.
Yes, sir. That's true, sir. Thank you. One more question from Dr. Rajeshri K. Is asymptomatic patient with CT score 4/25 need an antiviral drug?
What is it? What score?
CT score, it's 24 out of 25.
What's the CT score? I'm not.
Yeah.
I'm not familiar with the CT score. I don't know what that is.
Okay. Okay. Fine, sir. We'll take it up later. Then, sir, one more question from Dr. Prasad Buddha. Role of thrombolysis.
Rupashri,
Yes, sir.
Doctor's question on remdesivir. Let's not complicate things.
Yeah.
Let's not do all kinds of weird stuff and complicate things and raise unnecessary bills for the patients. You don't need any of those. Simple. If the patient is RT-PCR positive, patient's requiring oxygen more than 4 liters, X-ray is looking bad or whatever, that's all you need to start remdesivir. You don't need that score, this score, a high resolution CT, blah, blah, blah. So let's try to keep it simple. This is a pandemic. This is a wave that's going on. We don't have time to do all this. So let's not go with all that. Just keep it simple and treat the patient in simple terms. I'll take the next question. Sorry.
So I request Gautam to give the options to the people who wants to ask questions by hand raise button.
You were asking another question before I interrupted you. I'm sorry. Something about anticoagulation.
Yeah, 1 second, sir. Role of thrombolysis.
I just talked extensively on the D-dimer and anticoagulation. I don't know.
Yes, sir. Yes, sir. Yeah. There are few questions which are repeated. So I request Gautam to give the options to Dr. Prasad Budia.
Yes, madam.
Yeah.
Please unmute, sir. Yeah.
Please ask, sir.
Dr. Ramesh, it was excellent talk from you. I am Dr. Prasad from Davangere, the principal of SS Medical College. Sir, now in India, especially in Karnataka, we are coming with a scenario like what we call it's RT. The patients, the people who come have classical symptoms and signs of COVID, and RT-PCR test with a good throat swab comes negative, and then we have a tendency here to go for a chest X-ray or a CT scan, and CT scan shows the classical features of lung involvement, and history. With good history and examination, we can rule out other possibilities. Now we are coming into a scenario like, we don't know why the RT-PCR is negative, probably because of the mutant virus, where our original RT-PCR kits may not be finding those virus. So in a situation like this, the government is telling that we have to go like a COVID-like syndromic approach and treat them as COVID. So do you agree with this, sir?
Well, there's several aspects to this one. One is RT-PCR being negative is one of two reasons. One is maybe they didn't do a deep swab enough, or maybe the throat swab is not enough. This could be a false negative. When you say that the new variant is not being detected by this RT-PCR, I don't agree with that, because antigen test is the one that looks at the surface, but the interior core is still the same. So if there is virus, the RT-PCR will detect it. Now, if the RT-PCR is being negative, there could be one of two reasons. One, either the test was not done properly, or it was a false negative, or the patient already had the virus and has cleared it and is still having this cough and post-COVID symptoms and is now coming in. That's why his RT-PCR is negative and it's no longer contagious. CT scans do not get better. Patients get better. CAT scans don't get better. If a patient is coming in, why is the patient coming in? What is the criteria for admission? First of all, I talked extensively a few minutes ago about the CT scan. I begged you all not to do it unnecessarily. Sore throat, I have fever, I have cough. Okay, COVID, test negative. Send him home. Quarantine yourself. There might be still COVID, but you quarantine yourself. If you're still suspicious, come back in 24 hours, repeat the RT-PCR. If it's still negative, then you say, okay, you don't have COVID, stay home. Now, by doing a CT scan, invariably, you're going to find something, because the body is still healing. Like, for example, I give an example to my teaching staff is that, let's say that you have a house, right? And it's on fire. You put water on it, the fire's gone. Is your house going to look normal the very next day? No. It's going to take several weeks and months for that to repair, paint, and everything to bring it back to normal. Similarly, body. An infection happens in some part of the body, for example, in the lungs. If you X-ray, why are you not doing an X-ray? Because X-ray is not very sensitive to pick this up. The CAT scan is very sensitive. Just because you do a CAT scan, you find these things. Why are you treating an asymptomatic patient? Now, if the patient is symptomatic and you have a suspicion for COVID and RT-PCR is negative, then do a CT angio. Then you have to determine as to say, okay, does the patient require treatment or not? But you repeat a RT-PCR again. Not just one, twice sometimes, and that will help you. Now, if you want to treat a CT scan, then I have a severe objection to that, but it's a clinical scenario is different. So don't overuse CAT scans for diagnosing. If you diagnose, like there are several prominent people who got COVID this time, and they sent me a WhatsApp of their CAT scans. Everybody had something. And the radiologist is going to read it as multi-lobar, multi-nodular appearing findings noted consistent with COVID-19. This is a standard reading that they'll do.
Dr. Sachindra, please ask.
So for someone who's not an infectious disease trained person, who's not a pulmonologist, who reads a report like that, it's going to say, oh my God, that's such a big report. Send them to the hospital. But when you actually look at the CAT scan, and they sent me the CAT scan, I looked at it and said, how are you feeling, doctor? He's like, I'm fine, I'm at home. I said, just stay home. You don't need any treatment. They got fine, they got better in 2 days. So don't treat a CAT scan, treat the patient.
Good afternoon, Dr. Mahesh. This is Dr. Sachindra here. My question is, why are clinicians not looking at anti-tubercular drugs, specifically pyrazinamide? And as most of the Indian population are dormant TB carriers, are we looking at a TB epidemic in the near future in the Indian subcontinent?
Okay, so your first question is, why are we not using anti-TB drugs for COVID?
Yep.
Because there is no evidence that it works. Just like ivermectin, people are throwing ivermectin. There's not enough evidence that it works. So if you start assuming this is going to work, that is going to work, and you innocently start using pyrazinamide, only rifampin, and God forbid these patients already have some tuberculosis somewhere, you're already creating a multi-drug resistant TB going forward. So there's always this danger of using unnecessary, non-proven medications, throwing at it just because we're doctors. We have to be very careful. We have to think, what is the mechanism of action of the drug? This is an antibacterial drug. This is not an antiviral drug. In vitro, on a petri dish, it might show some effect. But how much of the drug do you have to give to a human being? What is the dose you have to give to a human being to make it really work? For example, ivermectin. In vitro, it requires a heavy dose to kill the virus. If you start using that kind of heavy dose in patients, what's going to happen to them? Do we have studies to show that? No. So instead of chasing all unknown entities, let's stick with, see, it's been a whole year now. It's been 1 year. We got a lot of data, a lot of myths that have been busted. So let's not create more myths unnecessarily by giving whatever you feel like prescribing. Stick with the facts, keep it simple, go with the protocols. I think you'll do fine.
Thank you, sir. I'll take a few, only 2 questions. We have a specific question from Mamta RH. I think she's dealing with a patient. She says, sir, D-dimer is very high with thrombocytopenia platelet count of 80,000 in a COVID patient. How to proceed? She's asking.
Go with full anticoagulation.
Yeah.
Go with full anticoagulation. If the platelets are dropping, give platelets. Don't be afraid to give.
Yeah. Okay. So one more question from Soumya Narayan. Younger age group are allowed to vaccinate next week. That is from 1st of May. It is open from 18 above. What are the contraindications for blood donation post-vaccination?
I don't see any contraindication for that.
They can go ahead with the blood donation, is it?
And please get your kids vaccinated. My 17-year-old son, he got vaccinated last month.
Okay. So based on that, there is one more question, sir. The government has given 18 years, but they want to know what is the minimum age for vaccination.
Well, they haven't studied anybody under the age of 18 so far. The studies are ongoing. But what I can say is give it. I don't see a reason why an adult can take the vaccine and a kid cannot take the vaccine. The mechanism of action is the same. So I don't see a difference.
Okay. Okay. Thank you so much, sir. I think we have few more questions they're asking. What we will do is, can we share your mail ID with the participants so that they can access you?
Yeah, sure.
Yes, sir. We'll share Dr. Mahesh K's mail ID. Anybody, and also we'll share the questions with you, sir, which are there in the chat box, and we'll host it in our website for their reference.
The reason why
Thank you so much, sir.
Is there time up or something?
Thank you.
Hello?
Okay,
Silence, sir?
thank
Yes,
you,
sir.
Dr. Rupashri.
Yes, sir.
No,
Thank you, Dr. Rupashri.
Is there enough time to take Q&A answers? I don't mind taking more questions.
Can we take
Okay,
few more
Rupashri
questions?
can continue with the
Question? Okay, sir. Okay, thank you
continue
so much.
with Rupashri.
Emergency situation, there are a lot of doctors who have questions. I don't mind answering all questions. I don't want to wait.
Sure, sir. Sure. Thank you so much. Thank you so much. So we'll take a few more questions which are there in the chat box. So basically, Santosh Kumar Shetty is asking, treating the COVID patients with SpO2 and clinical signs would be ideal than other investigation. He wants your comment.
I didn't understand.
Treating the COVID patients with SpO2, that is oxygen saturations and clinical signs, would be ideal than other investigations.
Well, yes. And first of all, confirm that the patient has COVID, and if the patient saturation is less than 94%, and but make sure you X-ray before you do anything else.
Okay.
I told you it could be other reasons also. We must make sure that we're not missing anything else.
Okay. Sir, one more question is there any role of methylene blue in COVID patients?
I don't see a role.
No role. Okay. And another question related to pregnant ladies, you have already answered. They want to know about lactating women taking vaccine.
I don't see a problem with that.
Yeah, they can go ahead. Okay. Yes, I think we have completed all the questions in the chat box. Thank you so much, sir.
All right. Thank you, guys.
Yeah, thank you, sir. Danan, sir.
Thank you, Dr. Rupashri. On behalf of the Vice Chancellor and the Registrar of Rajiv Gandhi University of Health Sciences, I take this opportunity to thank today's speaker, Dr. Mahesh Kottapalli. We thank you very much, sir, for your wonderful presentation today. And it has been very well accepted by many doctors. And the questions, what they pose, it shows that your presentation is very good. And then I take this opportunity to thank all those who are directly or indirectly involved in the organizing this webinar, today's webinar. And I thank our in-house officers, Dr. B.J. Mahendra and Dr. Rupashri, and our supporting staff, Mr. Shubasappa, for organizing this webinar. I thank one and all. Thank you, sir. Hello?
Yes, thank you.
Sir, VC
Thank
sir
you.
online. I request VC
Yes.
sir to give his closing remarks.
Yeah.
Yeah, Dr. Mahesh, it was
Okay, sir.
very
VC
wonderful.
sir.
On behalf of Rajiv Gandhi University of Health Sciences, I thank you so much for taking your time off your schedule and giving us this wonderful lecture. By the different questions that were posed by the audience, it shows that how much interest you have generated in them. A lot of doubts were cleared, and you could answer a wide range of array of questions. And the audience definitely got a perspective of international flavor of the treatment protocols of COVID-19. And my only wish is that all of us will stay together, be safe, stay at home, and then try to help each other and get over this pandemic. I take this opportunity once again to thank Dr. Mahesh for his very good lecture. Thank you so much. And I also thank all the organizers, my own team here in RGHS, plus Mr. Gautam for helping us out in this endeavor. Thank you so much. We'll sign off now and meet again on Tuesday, right?
Friday.
Friday. Thank you.
Thank you, guys.
Thank you, sir. Thank you so much.
Gautam, you can close the meeting.
Okay, sir.